Good afternoon, everyone. I'm Dr. Gursev Sandless. I hope you're having a wonderful day. So today I'm back after a short break to talk about, I think, the second part of the anorectal malformation series, which would be the male anorectal malformation. Now, when we talk about male anorectal malformations, I think what we really need to understand is that in boys, unfortunately, there is a big fundamental difference in anorectal malformation as compared to girls, because unlike girls, where the rectum will open onto the surface, whether it's as a rectovestibular fistula or as a cloaca also, in boys, this kind of an opening or an ectopic, an abnormal opening of the rectum onto the skin is extremely rare. In boys, usually there is no opening whatsoever, and you have a blind ending rectum which does not open onto the anal opening. And boys in these conditions usually need a surgery right at birth. Usually the surgery is done after 24 hours, where we would be going ahead and doing a diversion colostomy in these cases, where we bring out the large intestine onto the surface of the body and allow them to pass stool from there till they grow up, and they're about 3 to 6 months of age before we go ahead and do the definitive surgery. Now in boys, again, like I said, there are three types of malformation. There's a low variety where you may just need a small anoplasty, or maybe an intermediate or a high variant which may need a primary surgery or a staged procedure. But again, those are technical issues, and I'm not going to get into the details of these. What we are concerned as in boys especially is what is the level at which the rectum stopped before it, while coming down onto the surface, because you have to remember that all these structures, whether it is the opening, whether it is the muscles around it, whether it is the muscle which controls the anal opening, what we call an anal sphincter, and the rectum, now they are all supposed to grow and develop together. So if at some point of time the rectum is stopping at certain level, you have to understand that it's not just the rectal development which gets affected, but also the development of the muscles surrounding the rectum, which may not develop properly. And this is where I think in boys this takes precedence over girls, where in girls, because the rectum is opening onto the surface, it is usually accompanied by good development of rectal musculature, perineal musculature, and the sphincter, and you do not find so much problem of control in children, in girls. But in boys, this is what happens. So depending upon at what level the rectum stops, that dictates whether the child is going to have control later on in life or not, even if the surgery has been done technically correctly. So you divide them into low, intermediate, and high variety of malformations depending upon at what level the rectum and the surrounding musculature stopped developing. Now in low and intermediate variety, again, you can expect an extremely good control happening. Most of these kids would be about 90-95% incontinent by the time they are toilet trained, which is about 4 to 5 years of age. But when it comes to high variety of AR, where the rectal development has stopped very high, means the rectum did not even enter the perineum and facilitate the development of perineal musculature, these kids unfortunately are the ones who suffer the most when it comes to children with anorectal malformations. And with them, developing a right musculature, developing the right potty habits becomes very difficult. These high anorectal malformation kids are usually constipated. Now normally you would expect that if you don't have muscles, there should be no control, and you should have diarrhea. But what we are forgetting is that the primary function of the large intestine is to ensure that there is good water absorption that takes place. So what happens is, because the muscles have not developed, the nerves have not developed properly, so is the movement of the rectum as well. The movement of the rectum is also slowed down. So the stool does come onto the anal verge almost till the opening that you have created, but the body does not have the muscle power or the nerves available to push this out of the body, and that is something that does not happen. So contrary to popular belief that if you don't have good muscle control you're going to have loose motions, most of these kids are actually going to land up with constipation. And that is the fundamental of what we call as the bowel management program in these kids. See, a bowel management program involves multifactorial involvement. So if a child comes to us with say a diagnosed high variety of anorectal malformation, and he's having some kind of problem with the nerve development of the S2, S3, S4 level, then what we do is, the first thing we would do is do an MRI in these kids, see what is wrong with the nerves, see how the rectum and whatever muscle is available, are they aligned properly or not. Because if you are planning to give some sort of control to these kids, you need to know if their anatomy has been reconstructed properly or not. Now once the anatomical reconstruction is accurate or has been corrected and aligned properly, then the second thing that you'll be looking for is, can we develop a lifestyle for these children so that they can achieve some control. This involves starting them on biofeedback therapy in the form of physiotherapy and Faraday stimulation. It also involves giving them enemas, because then you can wash out the bowel so that they don't get soiling of their clothes. There are various ways to do it. You can do an antegrade enema by using the appendix as an opening in the groin, or you can do conventional enemas which are given. The advantage of giving enemas either way is that it empties out the entire large intestine. Now the large intestine, once completely empty, is going to take about 48 to 72 hours to fill up again. So the child need not take enemas on a daily basis. It can be done once in 2 days, once in 3 days. And the third aspect, to ensure that there is enough fiber in the diet, there is enough fresh food in the diet, which allows for a predictable transit time of the stool. Because you don't want that today you've given enema and then suddenly unpredictably the child has another motion in the evening, because the transit time of the traveling time of the feces through the large intestine has been shortened. So they need to have a well-developed diet plan which gives them a predictable bowel habit, and depending upon this predictable bowel habit, you are then able to decide and schedule their enemas accordingly. I know it sounds a little too much, but this is something which ensures that these children do not have soiling, they maintain good control over their bowel, and at the same time are able to lead healthy life. This is the best we can do for them till they reach about 14 or 15 years of age. Now after that, what can be done? Now if he reaches that age, there are other methods available. You can use muscles from the thigh which can be wrapped around the anal opening to give them a semblance of control, and then their dependence on enemas and other things does go down on the bowel management program. But I don't want to give any false hopes, but the fact remains that when it comes to high anorectal malformations, the best you can expect is about a 75 to 80% control in these children, and the rest of the control is to be achieved by non-conventional lifestyle changes like what I spoke about, the bowel management program. So that involves something that is going to remain lifelong. Unfortunately, we really don't have any solutions right now for high ARMs. When it comes to intermediate ARMs, of course intermediate ARMs do have well-developed musculature, and if these kids do not have good control, then like I said, in females you need to evaluate these kids, find out where the problem is. Is it the problem in the alignment of the rectum with the muscles? Is it a problem at the muscle level that they are a little weak? Or is a problem at the nerve level where the nerves are not sending out stronger signals? And all these can be then sorted out with biofeedback, with Faraday stimulation, with external or internal stimulation as the need arises. And these kids definitely achieve more than 95% control under all situations and go on to lead healthy lives in future. When it comes to low ARM, of course, they are as good as having everything in place, and it's usually just a little bit of a diaphragm or a small problem at the anal opening, and it usually needs just an anoplasty to be done. And there is no reason for these kids to have any kind of bowel related complaints, whether it is evacuation related or constipation related, as long as the primary surgery has been done properly. So this is in short about the male anorectal malformations. If any one of you have any queries, any comments, any suggestions on what topic I should cover, please comment below, and do keep watching the videos. Thank you very much. Have a nice day.